Okay, I guess we have stability of some kind. So the topics here, by the way, this is my own creation, no funding at all for this, that's my statement. The topics I'm going to cover about are the traditional DRIs, just a little bit to remind you what they are, and then the new issue here to be dealt with is DRIs for chronic diseases. Now that's not a new idea, but there's a new manifestation that I will describe for you about how these might be considered and treated for the development of DRIs. And not only for nutrients, by the way, but for other food substances, natural substances in food that may affect the risk of chronic disease. So I might argue that this is not really a nutrition question. This gets to a question of substances in food and how they might affect chronic disease risks, whether we call them nutrients or not. It's about chronic disease risk. So I'm going to talk about some of the key scientific issues, new ideas about DRIs that might be expressed not as single point estimates, but as ranges of intakes, and then a few new thoughts about upper levels. So just to remind you what DRIs are, they're a set of 6 standards. They're described as daily nutrient intakes, and they are developed by consensus committees of the national, what used to be called the National Academy of Sciences, now is the NASEM, Science, Engineering, and Medicine. And it's developed under contracts with both the US government and the Canadian government jointly. And so the NASEM sets up committees to respond to tasks given to them by those government agencies. Adequate intakes is where this all began. What are adequate intakes for nutrients, as you know, a long time ago. And then in the late 90s, they began to look at, as I mentioned earlier, upper levels, levels that might be associated with toxicity. Here are the key DRIs that you see now in the literature and is published by these committees. The average requirement, the recommended dietary allowance, the RDA, and then what's called an adequate intake. An adequate intake is used in cases where there is insufficient data to establish rigorously an RDA or an EAR. And they are based on just observed daily intakes in healthy populations where you think there is no evidence of a deficiency disease. So the first 3 here are all about deficiency, as I will emphasize. And then this so-called tolerable upper intake level added in the beginning to be added in the late 1990s. There are also DRIs for macronutrients and so forth. They are expressed in quite different ways. So here's a sort of intake-response relationship that you've seen before. I'm sure many of you, most of you, that have to do with what we're dealing here with respect to deficiency disease. And the curve, I want to emphasize the curve on the left. Does this light up here? Yes. So this is risk of deficiency disease. The adverse effect is deficiency disease. And with an essential nutrient, of course, the most highest risk intake is no intake. So you have, and that will affect, we believe, for deficiency diseases, 100% of the population. Everybody will have deficiency if the intake is 0. And then you reach some point where, called the RDA, where there is an intake where almost nobody will have deficiency. If we had perfect knowledge about that biologically, we'd say nobody would have a deficiency. So that kind of dose response or intake response curve is really restricted to the endpoint of deficiency disease. It's a rare kind of dose response relationship where 0 exposure leads to disease in 100% of a population, and you go to some exposure where everybody is protected. That's a rare kind of dose-response relationship. And then at some point, as you move up the intake scale, you reach a point where toxicity occurs with most nutrients and other food substances. If you get to a sufficiently high dose, you'll get some kind of toxicity, and the idea is to avoid that. You need to establish what's called a UL. So that's the traditional model. for the intake-response relationships, and you cannot develop DRIs without intake-response relationships, as I will emphasize. Okay, so the characteristics of that dose-response curve, this is a bit of a repeat, but one way to think about this is that substances, as I described in that last figure, are nutritionally necessary, and they are by themselves necessary and sufficient to completely avoid deficiency disease by themselves. If they are completely absent, they're capable of causing disease in 100% of the population. So I'm repeating myself here, but it's an important point, because when we move to chronic disease endpoints, these principles do not apply. Now, committees began looking anew at DRIs in the mid-90s, and that work continued for about 10 years at the NASEM. A lot of them were published during that period, DRIs. And some of the committees ran into situations with certain nutrients in which the studies were revealing chronic disease endpoints, not deficiency disease endpoints. So these committees made an attempt to publish some kind of reference value based on a chronic disease endpoint. And these are 4 key ones here that the committees did. So dietary fiber is related to coronary heart disease. The committee did not establish an RDA. I mean, dietary fiber is not an essential nutrient. But they did establish something called an AI for dietary fiber that they thought would avoid at least some risk of chronic disease. So they were trying to force this data about chronic diseases into this model that was developed for deficiency diseases. And I'm not blaming them. They had nothing else to turn to. So these were published, but there are some problems with all of these, not necessarily in the values they produce, but in the methodology used to get there. Now, one thing to point out about chronic disease endpoints, that the intake-response relationships I just described a few moments ago don't apply for chronic diseases. Chronic diseases are completely different creatures. The last sentence here, no single substance would be both necessary and sufficient to cause or avoid a chronic disease in more than a fraction of the population. So if everybody were affected, for good or for bad, by a substance and a chronic disease endpoint, we would call that substance, I think, a miracle. That doesn't happen with chronic diseases. They're much more complicated and they are multifactorial. So no single substance is going to have that characteristic. So that has to be taken into account in dealing with chronic disease endpoints. This is a sort of conceptual model of that, indicating that all of these chronic diseases, whatever they are, will have some background risk in a population, and some substances might decrease that risk as intake increases. I could draw another graph, something like this, with other substances like saturated fats, where the risk would increase with increasing intake. But these are quite different intake-response relationships than you'd have for a deficiency disease. This is the simple definition of a chronic disease as given by IOM. Everybody knows pretty much what these are, although there is some ambiguity about what a chronic disease really is, I do understand. But the common ones that show up so far are those that are listed here on this slide. And there's evidence accumulating, good and bad, and sometimes very good and sometimes very bad, but a whole range of kind of issues have been arising in recent years that substances in food, nutrients or other food substances, have some effect on the risk of some of these diseases. And so how do you take account of that information to make recommendations, really, for intakes of those substances? And those recommendations, how much evidence, what kind of evidence do you need to make good recommendations for those kinds of endpoints? So this began, the Canadian and US governments together jointly formed a panel about, I think, 4 years ago, of experts from both countries to look at the question of chronic disease endpoints for nutrients and other food substances, as they are called, and asked the question, what are the options for deriving DRIs based on those chronic disease endpoints? Not to propose a methodology, but to describe what the issues were and set up a bunch of options for looking at these questions for getting good and rigorous approaches to developing DRIs. So this paper was published. This is in American Journal of Clinical Nutrition in 2017. It's a report of the panel. Panelists are listing there, and the options are laid out in this report. This is well worth reading because it gives you a really good sense of the complexity of this issue. It has buried within it are all the complexities that we heard from the first two speakers this morning that I will not discuss, and more. It is not a simple issue at all. But this is, I think, a very good summary of what we're up against and what are the ways we might deal with it. And then the governments then asked the National Academy of Sciences to look at those options and then develop what are called guiding principles. Is that what this is called? Yes, guiding principles for developing dietary reference intakes based on chronic disease. And I'm going to run through those principles. This report came out last year. It does not describe any DRIs for chronic disease endpoints. But it's now being, when committees are being formed to deal with chronic disease endpoints, they will be asked to follow the principles set out in this report. So it's a pretty important report for this purpose. There is already a committee underway dealing with sodium and potassium again, and chronic disease endpoints for those two nutrients. And the committee is asked then to follow the principles in this report. So that committee is already underway. The work is already underway. Here are just a few of the problems that arise. You all know that causal relationships are extremely difficult to follow for any single substance. So there's always issues of what causality that come up. The main issue having to do with kinds of evidence you can collect about chronic disease really significantly relates to whether there are good surrogate markers for disease, biomarkers for disease, because in many cases you cannot wait for years and years and years to understand real disease outcomes. You have to have surrogate markers in many cases, what's required there. Chronic diseases are multifactorial. I've already mentioned that problem of intake response. How does that also relate? Because intake-response relationships are complicated and they're highly variable, we see, from different studies, but you cannot get to a DRI without intake-response relationships. So those are just a few of the problems that arise. So the minimum scientific requirements then, as laid out in the Guiding Principles report, is that first, you need evidence of a causal relationship between the substance and the risk of chronic disease, and you need quantitative information on intake risk relationships, and then a specification of some range of intake over which risk will be reduced. Range of intake. So range of intake is not a point estimate, as you will see. So the old ideas about DRIs, which are all point estimates, will not apply in connection with chronic diseases. But it's a much more demanding database here to get to that range of intakes. So all through the options report, the question is posed, how certain do we, knowing that you can never have perfect certainty about any of this, how certain do we need to be to get to a chronic disease based DRI? Now, how certain you need to be is not exactly a scientific question. There's a policy component to that kind of question. But the committee was asked, nevertheless, to deal with the question, how certain do we need to be that there is a causal relationship? How certain do we need to be about the intake-response relationship? So the committee went ahead and tried to answer that question. It turned, of course, to systematic reviews as a starting point for all of this. And there's a long discussion about the the reviews as they were initially set forth to deal with medical interventions of one kind or another, and how you proceed through a systematic review, and then when you've done that, how you then assess the outcome. The committee recommended one particular approach to dealing with the evidence and sort of rating the certainty of the evidence coming out of a systematic review. This is a system called GRADE. Many of you, I'm sure, are familiar with it. It's now quite widely used to evaluate systematic reviews and to characterize the evidence emerging from it. Grading of recommendations, assessment, development, and evaluation. It's a, as I said, widely used system, beginning mostly, it had its origins in evaluating pharmaceutical interventions, but now is much more widely used. So the committee recommended that because of the wide use of this system in rating evidence, that GRADE be the method used to evaluate evidence for nutrients and other food substances and chronic diseases. And so it's in there as a strong recommendation in this report. I think if a committee of the National Academy said, well, we want to deviate from this a little bit, and they had a good reason, that would be fine. They're not bound to it in that kind of sense. But it is a good system. It seems to be widely used. I know there are critics of, well, it considers both randomized control trials and also observational studies. It does not just dismiss observational studies, but the system itself begins by giving, the evidence is rated from sort of high to low confidence or high to low certainty in the outcome. And evidence from RCTs is rated initially very high, and initially evidence from observational studies is rated very low. Evidence from RCTs may then be downgraded according to characteristics of the individual studies. So rating is modified downward. I show that over here on the left. For RCTs, depending on things like precision or consistency and so forth, bias, risk of bias in the study and that kind of thing. And then with observational studies, evidence can be elevated in certainty if the effect is very large, you have a good dose-response relationship, things of that nature. So the system, GRADE system, does not just dismiss observational studies, and of course you can't do that. That would not be right anyway. They just give them less weight initially, and then the rating is modified upwards or downwards. The one thing about this, the system that I find a little deficient, is that it seems to give no weight to understanding mechanisms of biological action of the agents and whether that could add to the evidence one way or the other. It doesn't immediately dismiss that kind of evidence, but it doesn't seem to give it a lot of weight. I would have personally given that more weight, but that's not what the GRADE system does. So the conclusion from the committee was that, as I said, the evidence is rated as high certainty, medium certainty, or low certainty, or no certainty whatsoever in some cases. So the committee said for causation, to develop a DRI on the causation front, you need at least moderate evidence of causation from the GRADE system. And then also, this committee, the Guiding Principles Committee, then moved to the question of intake response, which is not in the original GRADE system, but to try to also evaluate intake-response relationships with respect to the certainty of the evidence, high, medium, or low, and asked for DRI development that both causation and intake-response evidence be at least a moderate level of certainty, not necessarily the highest. So that recognizes perhaps, I think in most cases, if we're dealing with pharmaceutical interventions, high certainty is generally required, for example, by FDA. So this committee is made a judgment that moderate level of certainty would be adequate for DRI development and chronic diseases. This is one tool that I'm still learning about, that several members of the committee, the sodium panel that we're now working from, is a tool that's available online to evaluate the general thoroughness or completeness of any systematic review. It's quite an interesting tool worth looking at to see just how well the systematic review has been done. The surrogate marker issue comes up over and over again, and there's a lot of discussion in this report about what it takes to get a qualified surrogate marker, because this is extremely important when we're dealing with chronic diseases. And there aren't a lot of them available, so this is right now a fairly serious limitation in how we get to chronic disease endpoints in the absence of studies, RCTs, that get us all the way to the chronic disease endpoint. So there are some qualified markers. You saw that earlier that blood pressure was used earlier for sodium in establishing a chronic disease DRI. That is controversial. There's most of the evidence I find on blood pressure and chronic disease endpoints comes from studies in which, it's good evidence, but it comes from studies in which all the interventions have been with pharmaceuticals to reduce blood pressure. And the FDA considers that still a good surrogate, that is blood pressure, for chronic disease endpoints, but it's all pharmaceutical evidence. So the question arises, if you reduce blood pressure by reducing sodium, do you have the same effect? That's something the committee is now considering. Now, getting finally to the intake response, here you need to look at we know that risk will change with dose or intake, and you have to have some evidence here to establish a DRI. We look really basically at the slopes of these intake response curves, and if slope is pretty constantly zero, then there's no effect. If they're increasing or decreasing, then there is an effect in one direction or another. One thing that does come out in the analysis is that you've got to be sure that in recommending these ranges as possible ranges of beneficial intakes, you've got to avoid going below the RDA or above the UL. So it's got to be in that range that you're looking at the intake-response relationship in that range for chronic disease endpoints. So these are sort of typical examples. You'll find them in the report of what they might look like. And you've seen this, we see this for a few nutrients now. We've got some information. Here's one where as intake increases, the risk of chronic disease decreases. Here's the RDA over here, just for illustration purposes. And so that range, why is this not showing? This range here on the bottom might be a range of acceptable intakes, and over which there is a decreased risk of chronic disease. That's what this is meant to illustrate. So that range is a DRI under this model. How that then translate, how do you use that kind of information or that range in practice is a question not yet resolved. But it did seem wrong to the committee to think of these as point estimates. They are ranges. And so you're looking at the slope, and where the slope begins to flatten out again, or you're uncertain about the slope, you have to make a judgment about where that range begins and where it ends. This is where you have an increasing risk. Sodium might look like this, for example, with blood pressure. You reach some point where you get increasing blood pressure with sodium intake. So there is, if you accept that blood pressure is a surrogate, if you accept that for chronic disease, then you would say that over this range there is, with decreasing intakes, there is decreasing risk of chronic disease until you reach where the slope goes to zero. And you make a judgment then about the range where you get decreased risk and then no increased risk, if you like. They could all be translated. There are going to be some that look like this that really complicate the world a lot, and there are going to be even more complicated relationships. So that's all remains. This is still something to be worked out in practice as you get more and more intake information. A little bit about ULs before I close down. ULs are really about toxicity. They're not about chronic disease. And this is the definition. They have been traditionally derived in the way we derived ADIs or TDIs for other food substances. Similar kind of approach. But there are a lot of problems, I think, still to be resolved in getting good ULs for nutrients and other food substances. The methodology still needs some work. This is not a topic, by the way, covered in the Guiding Principles report. They don't talk about new methods for dealing with ULs. The only comment made about ULs in the Guiding Principles report is that it should not be used to deal with chronic toxicity, chronic diseases. It's based on more traditional measures of toxicity. So these are sort of traditional UL endpoints. None of these is really a chronic disease, and that kind of use of the UL, the committee asks to continue. So this is a repeat of what I just said. There's good reasons not to base these on chronic disease endpoints. So the chronic disease endpoint would be the intake-response relationship and some range of intakes which we think is beneficial, as described earlier, yet to be named. I'm not sure what it's going to be named, but it will be a range and not the kind of point estimate you have here. I want to make a comment about the UL derivation. The particular approach that's been used for ULs and nutrients beginning back in the 90s is very much like the approach to ADI development for food additives or TDIs for food contaminants, where you'd have some observed no effect level from some study, animal or otherwise, and then uncertainty factors to deal with animal to human variation and variation within the human population. The basis for these factors, they've been used for years, but there was not a strong basis for these factors in many cases, except they're probably cautious, but we don't know how cautious. There's a lot of work going on now to maybe move to more quantitative estimates of risk for threshold effects like these. They all assume a threshold here, but they don't really tell you how much risk remains at the UL. It's not zero, but how much risk really remains, how much residual risk is there. Remember, these thresholds, they are for individuals. There are thresholds, no doubt. But then for the population, you have a distribution of thresholds in the population. They're not all the same thing. So if you then begin to look at those thresholds as distributions in the population, you can then begin to look at other approaches to defining ULs and other measures like the ADI. So the ADI is fine for sort of these bright line decisions, yes, no, safe, not safe, but they don't really tell you what kind of risk you might be accepting at that level. And they're not good for looking at risk-risk trade-offs at all. They're just bright line points. So moving toward a more quantitative estimate of the risk for these threshold effects will, I think, be useful. And there's a little appendix in the Guiding Principles report which describes how you might do this in connection with nutrients. I think it's worth thinking about. So the risk assessment in this case is where you look at the fractions of a population estimated to have some threshold exceeded. And it's never going to be zero fraction, but at some point you decide the safe level, whether it's the UL or ADI, what's the acceptable fraction, much like you do in the case of, say, quantitative risk assessment for carcinogens. The same idea here could be applied. So this could get to better decisions about nutrients and other food substances as well. It's going to take some development, but there is work underway in the risk assessment world about this. So this is a repeat of what I've already said, why it might be advantageous to think about quantitative approaches for threshold effects. I will skip that one for now. A few other challenges that come up, and I think I'm just about done. There's the report talks about the problem that I think you all know so well in studies of nutrients or other food substances. Intake evaluation is very suspect. It is very difficult to do well with high accuracy. Much improvement needed there. Qualifying surrogate markers is, I think, a really serious stumbling block to moving toward DRIs for chronic diseases. It's going to be fairly limited. There's always the issue of extrapolation from studied populations to others, and we're going to see cases, no doubt, where intake-response relationships depicting benefit are going to overlap with intake-response relationships showing harm. And so you're going to have some kind of trade-off there that is not so easy to untangle. So those are all challenges that will come up, I'm sure, as this field moves ahead. So not all questions are settled by any means, but the Guiding Principles report really gives a pretty good roadmap for the future. It's relatively clear. I've already mentioned the sodium-potassium study, which is already underway, expressing these DRIs as ranges is no doubt going to express, I think the sponsoring agencies in the government are already worried about this. What are we going to do with ranges, not point estimates? The Guiding Principles does not answer that question about how implementation here, useful implementation of these can occur. It also points out here, number 4, that the methodology described for nutrients is perfectly applicable to other food substances. So you know there are other so-called bioactive substances that go by other names in foods that have effects on chronic disease. How good is the evidence? Not sure, but the method applied here for nutrients, things we call nutrients, has perfect applicability for those other substances. So in a way that kind of opens up that field for DRI development for other food substances as well. I think I will stop there. Thank you.
Right, just before lunch, but we do have time for a couple of questions if you have them for Dr. Roderick.
Thank you for a wonderful presentation, Joe. I wondered what the evidence is that non-nutrient food substances and nutrients can be regarded as similar, particularly because at the start of your presentation you pointed out that U-shaped model doesn't seem to apply to xenobiotics or what have you.
Yeah, so if the nutrient, in my mind, if the nutrient substance is affecting chronic disease risk by pathways that relate to its ordinary nutrient properties, characteristics, that might be quite different from other food substances. But my guess is that these are affecting chronic disease risks in the way other substances might affect them, that it's not related to the fact that they have essential nutritional qualities. But I'm not sure about that. What I'm saying, the method described here for dealing with causation and intake-response relationship is the same whether it's a nutrient or not, if the endpoint is a chronic disease.
Thanks, thanks, Joe. Outstanding as always. It occurred to me when you were talking that, and I guess I just wanted to ask a question. It seems to me that there may be more dose-response data available for non-nutrients because of all the stuff that was done on health claims than there is for nutrients. Is that just bad thinking, or is that probably accurate?
I would guess that's accurate.
Yeah, it's very interesting to me that there is probably more for non-nutrients than nutrients.
Yeah.
Huh.
I don't know. That's a great question. I mean, ethanol is a non-nutrient food substance, I guess. There's quite a lot of data on ethanol. Yeah. So you can imagine there's nothing here which would exclude a DRI for ethanol. Yes.
Yes.
Or caffeine. Yes.
Sorry. So you talk about the range for chronic disease. So if you have a disorder like hypertension where it may be dependent on sodium and potassium at different level,
Yeah.
how would you deal with that? I mean, when you talk about range, are you talking about range of sodium and potassium or just sodium?
Well,
How would you translate that?
the sodium by itself kind of looks like this,
Right.
where if you're talking about blood pressure. And you see a range, there's always debate about the upper end and the lower end of that range and whether it's linear or not. That goes on and on, but that's observational. There's also information on the effect of potassium, but it's mostly separated from sodium. And there are a few studies where they look at the combination of sodium and potassium. It's a fairly weak database, but potassium has a beneficial effect for sure. It's just the evidence is less strong for sodium. But right now, the evidence points to sodium acting by itself to increase blood pressure.
Well, a lot of studies that shows that actually have potassium in the diet. So, I mean, that's the thing I'm trying to wrestle with, whether
Yeah.
I don't think there was a clear study that shows the independent effect of sodium away from potassium. I don't know. I mean, that's what I'm wrestling with, because if you have a lot of several nutrients responsible for a disease, and then when you talk about ranges, then you're really talking about ranges in terms of the single nutrient range
Yes.
or versus a combination.
Of a combination.
Right.
There's always the possibility of a combination if you have the data. But I have to be a little careful talking about this because I'm on this committee and I can't say too much about where we're going. But I will point to, there is a systematic review now published by the federal government on sodium and potassium by the Agency for Healthcare Research, yes. Yeah, so that report is out, and the questions you ask are answered in there. Our committee is supposed to rely upon that report, although we're not completely bound by it. But that is the systematic review that I mentioned that is planned for other nutrients down the line, same kind of approach as the starting point. So I just can refer you to that for the answer to that question. But I think most of the evidence points to sodium acting alone here in this case. It can be tempered by potassium for sure. Not the experts I listen to on this one say we take more sodium than we need and not nearly enough potassium in our diets. Maybe that's enough? Okay.
All right, thank you very much
Okay.
again.